Okay, let's get started today. So I'd like to welcome you all. My name is Levi Wolf. I'm here with my co-host, Rachel Franklin, and we put on the Spatial Analytics and Data seminar series every week. We invite a speaker to come talk about a different topic in spatial analysis and data. Sometimes we do interviews with people in the field, famous for various aspects of spatial analytics and data. We have a YouTube channel where all these things get posted. And so we're really glad to welcome you today to hear my friend and colleague, Gareth Griffith. He is a senior research associate at the Bristol Medical School at the University of Bristol. Gareth is in the Population Health Sciences unit, and he uses large longitudinal data sets on social and genetic factors to uncover issues of conceptualization and measurement across a variety of health outcomes. He seeks to understand the causal and structural properties of health and inequality across society, and is super great speaker that we're very glad to have. That was definitely in the script. So I think I will hand it over now to Gareth, who will give his talk. So thanks a lot.
Sure, thanks for that, Levi. Those things always sound much more grandiose when they're said out loud, and you're sort of asked for them in advance. You're like, I can type a thing about me. So I apologize if that sounds like myself. I'm not like that. I'm going to attempt to share my screen, despite being like 10 years into a pandemic. I'm just gonna double check that that is working. You should see a blank screen and then hopefully a presentation on it. I get a thumbs up from Levi or Rachel.
Yeah, it looks good.
Sweet. Okay, so this is a talk that I, if this isn't obvious from the strike through, this is a talk that I initially started going over with my colleague Gwilym Owen, who I believe is in here somewhere, about a year ago, about how we might conceptualize spatial inequalities in COVID-19 outcomes. So as Levi alluded to, I'm in the medical school now, but I was previously a geographer. That was where I did my PhD. It's where I met Gwilym, also doing a PhD. It's where I met Levi. I was in that same department. And we were thinking about why we've done lots of health geographical stuff before, and we were thinking why might COVID-19 and COVID outcomes be a particularly interesting topic for spatial analysts. And there are several reasons, which I think I'll go through, why we might anticipate that this would be more relevant to spatial analysts than other health outcomes might be. And we'll talk through what some of those are. But first, you've got to do the obligatory sharing of embarrassing photos of colleagues. This is Gwilym Owen. He's in the chat. He looks like that. That's exactly, he has ears in real life. This is Professor George Davey Smith, Professor David Manley, and Professor Laura Howe, all of whom worked on some of this work with me. So I just would like to acknowledge up front that I am not smart enough to come up with any of this stuff on my own. And in the absence of these people, I would be spouting gibberish. So I think I would, in general, I've had several conversations about this kind of stuff, about spatial inequalities in COVID with several colleagues, and without wishing to strawman them unnecessarily, I think I've tended to come across people who think along the lines of, yes, obviously there will be inequalities with respect to COVID-19, there will be inequalities in COVID-19 outcomes. No, I haven't really thought that hard about what those will be structured with respect to. No, I haven't really thought that much about when they will have been greatest and what might predict them being greater. So with that in mind, having strawmanned all my colleagues, I think this genuinely does represent a reasonable proportion of colleagues here in epidemiology, at least. And I'd just like to take a moment to invite you guys to consider what you think is likely to be our outcome or our conclusion here. Do we think that spatial inequality in COVID-19 outcomes is likely to be high? Do we think that it's likely to have been consistent over the pandemic? And if not, do we have a prior on when we think it will have been greatest? And this was, if you were happy to say, but I don't expect anyone to unmute themselves, but if you were happy to speculate on what you think might drive inequality, do you have priors on what it would be? And so I'm going to do a little bit of a roundabout talk here. I was talking to Levi about this earlier. There's some things which I think, having done this and having spent, as I said, almost 2 years in an epidemiology department, some things that I think geographers could do a little better when it comes to thinking about causal inference. And my loose musings on those in this sense are gonna come across in three ways here, and then I'll make some conclusions at the end about what I think geographers could do, spatial analysts could do around doing better causal inference. But essentially trying to infer anything about causal processes from observation data is just really hard. There are loads and loads and loads and loads and loads of ways in which true causal processes, or there are loads and loads of alternate causal hypotheses which might be producing the patterns you see in your manifest data. And I think in these three questions, we'll talk through, certainly the first one is more explicitly about why I think geographers don't think that much or that carefully about this kind of stuff. So if we're going to select a COVID-19 outcome, we're thinking about our research question, what are inequalities in COVID-19? There are three common COVID-19 outcomes, and this is certainly the case through the first half of the pandemic when this initial paper was written. So I should have said up front, this is an update of some results which we had published in the Journal of Epidemiology and Community Health earlier this year, but we now have updated data because the ONS provided it. And so when we were selecting our outcome for this data, for this analysis, there are three common COVID-19 outcomes. The first is COVID-19 self-report, and this was particularly prevalent, particularly, that's a specific word now. This was particularly common as an outcome for analyses early on in the pandemic when testing was not particularly common. We could also look at testing and look at COVID-19 positivity as an indicator of whether you had COVID, or we could look at COVID-19 mortality. And I'm going to go through a little bit why we chose the one we did, and whilst in doing so, hopefully go over some sort of causal considerations for why these things might end up having different biases inherently baked in. So outcome selection for the Y part of your model, if you're doing modeling, outcome selection is intimately tied to your sample population. So if we consider our different outcomes that we might take, they're going to have different biases baked into them even if we have full information across the population in them, they will still have different biases baked in. Right? The people who get COVID tests might be getting COVID tests for different reasons. The people who are self-reporting that they have COVID might be different for different reasons from people who don't self-report that they have COVID or don't even log any outcome at all. And these biases, these differences, these non-random differences between populations matter if we're attempting something like generalizable prediction or causal inference, as the causal structure of our target population might not match that of our sample population. So if we're aiming to generalize out of sample, even though in a predictive capacity it might not matter if we get the causal structure right, we still need, we don't need to get the causal model right, we still need the causal structure to be the same for the transportability of our estimates. So I am of the opinion that these things are always easier with examples. So having been in a health department so long, I go for health examples now, but we could do this with, in fact, we're writing some work on doing this with spatially informed variables now. But to say that we want to know the association between drinking alcohol and lung disease, right? This is our predictor. I don't know if you can see my mouse, I hope you can. Predictor and our outcome. And so there are several ways in which a relationship between these two things might arise in our given data set. The first is if we have a confounded relationship. So I'm going to go over very quickly go over something called directed acyclic graphs. I can, if people have questions on these at the end of this, I can go over them or signpost to references on them, which are written by people who are much better at explaining them than I am. But if we were to look at a relationship between drinking alcohol and lung disease, if there is a common cause of both these things, then our estimate of drinking alcohol and lung disease in just an observational data set will be biased by that common cause, or could be biased by that common cause. So if we see a strong observational association, which has been noticed before, a strong observational association between drinking alcohol and lung disease, can you think of any potential common cause which might be confounding this relationship, which might be driving the association that seems to be there in our observed data set? And I hope, having not asked anyone to unmute, I hope that possibly someone thought that smoking might be a thing that would confound these two. And that isn't to say that there's going to be no relationship between drinking alcohol and lung disease. There is some, I think the latest I read on it, there's some evidence that drinking beer specifically is bad for lung disease over and above the effect of adjusting for cigarettes. But if we have a confounded relationship, the main thing is that in our analysis, we want to adjust for smoking, right? So if we want to know the effect of drinking alcohol on lung disease, and we have all of the information on smoking on everyone in our data set, we want to adjust for smoking. We want to include smoking as a variable in our model. This, I think, is relatively well understood in spatial analysis, right? We commonly think of covariates that we might adjust for in our analyses. This is less commonly understood, and this is what's called a collider-stratified relationship. So our relationship becomes biased if we condition on a thing which is a common consequence of these two. So if we were to collect data on hospital admissions in our observational study on these two things, so drinking alcohol and lung disease, if we were to collect data on who ends up in hospital, we wouldn't want to adjust for it because that is a consequence of both those things. And if we adjust for the consequence, we may bias our association away from what it truly is between alcohol consumption and lung disease in an unselected sample. Now, this, I think, seems reasonably intuitive. It's something that I think you can wrap your head around fairly easily, is that you want to adjust for confounders, you definitely don't want to adjust for colliders. The problem is it's not simply whether to adjust for variables, which is problematic for us as researchers. So if we think about collider bias in the context where our exposure and our outcome, the two things we're interested in, so say drinking and lung disease, are both associated with participation in the study in the first place, then any relationship we observe in our study could be biased by collider bias, by collider stratification bias. And I like this example because it means I get to baselessly slander Hollywood actors. So if we are to imagine that there is genuinely no relationship between how buff you are and how good you are at acting in the general population, I have no idea whether that is true, but I'm going to assert it for the sake of argument here. There is no relationship between how hot you are and whether you're good at acting. If we know that to get into Hollywood, or to become a big actor in Hollywood, you have to be really good at acting. That's one way to get in. Or you have to be really hot. That's another way to get in. And we assume that these things are normally distributed in the population. There are going to be some people that are both very hot and very good at acting. But those people will be quite uncommon because these two things are unrelated in the population. There will also be quite a lot of people who are not very good at acting and not very attractive, but they won't be in our Hollywood sample. And what happens if you condition on these two things is you get something that looks a little bit like this. So in an unselected sample, in the blue dots, the blue data, we have no association between these things. These are two normally distributed variables. But because we've created a selection process such that we've only sampled people who are successful actors, we've induced a negative relationship between these two things because we've selected into this corner of a cloud of data. And I think that broadly, although it does get a lot more complicated than this, broadly, you can kind of think of the likely direction of your bias using a hypothetical cloud of data here. So if we were to select negatively on acting ability and negatively on attractiveness, we would also induce a negative relationship because we'd shift it into this lower left corner. And similarly, if we had one positive and one negative selection of exposure, association with selection, we'd induce a positive relationship. So earlier this year, it isn't even earlier this year now, it's ages ago, we had a paper published in Nature Communications looking at how collider bias might undermine our understanding of COVID-19 disease risk and severity, subsequent severity having been infected with COVID-19. I should stress that collider bias in general is much more complicated than this simplistic understanding over here, where it's sort of, you can imagine which corner of a quadrant you're shifting into. The degree to which your small selection biases can actually distort your true association is quite alarming if you go through simulating it, and I wrote a little Shiny app as part of that paper, which does so. So I invite you to go and look at that if you can be bothered. So if we think about now in the context of our possible COVID-19 outcomes, which of these might give us the truest representation of an underlying genuine COVID disease? If we take something like COVID-19 self-report, which, as I said, was very common early on in the pandemic, we know that people who voluntarily self-report in studies are non-random. They have to be non-random because they have to download an app. So this was the reason this paper eventually came about, was because we were doing a bunch of work with some people in the COVID symptom study in King's College, and they developed their COVID symptom study app, which possibly some of you in here might have downloaded. My mum downloaded it. I downloaded it at one point and then binned it. But they were essentially aiming to get millions of people to download this app, and then amongst them look at things which predicted your risk of getting COVID, or predicted your risk of progressing with severe COVID once you got COVID. And the issue with this, when we got sent a data freeze of this to try and help them do QC, like quality control stuff on the data. So it's mostly just trying to filter nonsensical values like people with BMIs of 30,000 and stuff. So we're just like, okay, get rid of those people. Get rid of the people who are super old. As in not get rid of the super old, but as in people who'd put in that their birthday was 1800 or something. And we know, so one of the things we got talking about when we were doing this is that we know that participation in apps is non-random, right? And we suspect that it's non-random with respect to our exposures of interest, such as age, big key one for COVID. We think that probably younger people are better at using tech, better at using apps. It was advertised on the BBC. We know the BBC reach isn't uniform. Critically, and the alarm bell ringingly, is that it's probably non-random with respect to COVID. So if I think I have COVID, it's much more likely that I'm going to download an app that's called the COVID symptom study. And so we may find that in our sampled population, given that both of these things we know plausibly affect app usage, we might find an association between these two things in our observed data set of people who've downloaded this app, which might not generalize outside that population. So as part of this initial work, I made a little map of, so my immediate thought, being a geographer, hello, I'm here speaking as a geographer, was that this is going to be spatially non-random, right? It's the reach, we know the reach of the BBC isn't random, we know that it's going to be clustered in urban centers. And so we looked at the COVID symptom study and mapped local case rates, we mapped local usage of the symptom study app and just the population denominator, and looked at how overrepresented different areas were. And so this was a piece of work I did as part of this. And basically you see that some areas are up to 6 times more likely to be involved in this sample. And we know that there are many things which may associate with this map. You show this map to anyone, there will be area level factors which could associate with this. But the immediate one to me was deprivation. So we were like, what proportion of the ascertainment in our local participation in the app could we explain with deprivation? And it turned up about 20%. So we sent a letter to the author saying, please don't look at IMD or anything with deprivation in this study because it might be biased. We suspect it will be biased. COVID-19 caseness is an interesting one. So this is interesting because I suspect it's become, this is probably less true than it was at the time we wrote the initial draft of the paper. Sorry, the initial version of this paper. The key point for this is that collider bias isn't solely important for things which are directly causally related to selection. It can be related to things, it can distort associations between things which share a common cause with something which does relate to selection. So for instance here, if we hypothesize that healthcare workers are more likely to smoke, and we know that healthcare worker is a common cause of both smoking and COVID testing, then we might see a distorted relationship between smoking and COVID-19 severity. And that means that amongst our people who are tested for COVID, if we know that certainly this was true again earlier in the pandemic, but it's become more obvious as we've gone on that deprivation largely predicts testing. And so if there is an association between your deprivation measure and your COVID test positivity, you need to know that isn't just due to the fact that deprivation has predicted you getting tested in the first place. This is also, you can, I don't discuss it here. I took the slide out just before because I thought I'd have too much to say. But this is also, this can be, or a special case of this is something called index event bias when you stratify on, or when entry to your data set is conditional on one of these outcomes. So if you look just amongst people who test positive for COVID and try and look, say, for predictors of long COVID or predictors of death or some sequelae of COVID, some sequelae from your initial index event, because you're conditioning on the index event, the people in your baseline will be unusual. So if you were to imagine, say, early on in the pandemic, there was some work on looking at why it seemed that smoking was protective for COVID-19 progression. And it basically turned out that most of these studies were done within hospitals. And that if you imagine there are 2 possible ways you can get into a hospital, one is that you are a smoker, one is that you have COVID. If you look at those 2 populations, the people who don't have COVID will be much, much younger in general. You basically, if there is some latent risk for you dying, smoking is bringing forward that risk. And so amongst those groups, they will not be at all age matched. So the people who end up being smokers in hospitals will be much younger than the people who aren't smokers in hospitals. And that means that when these studies were looking at how long people tended to survive, they would find that smokers with COVID survive much longer. This is a ramble that wasn't actually, I literally deliberately took that out so I didn't talk about it and then talked about it anyway. So as part of this initial paper, we looked at the UK Biobank, which is a study, a genetically informed study, which has about 500,000 people in. And we wanted to look at basically to head off at the pass anybody looking amongst this to see if things associated with testing, or sorry, things associated with testing positive, because of the 2,500 things we tested, about 900 of them associated to a strong evidence that these things were associated with testing. And that means that amongst that population, associations you find between any of these 900 variables and testing positive might be distorted. So we eventually concluded that COVID mortality was probably the most useful metric for true COVID outcomes here. Because certainly early on, COVID-19 testing occurs regularly in hospital settings. We knew that that was the case. We knew you were more likely to be tested if you were in a hospital than if you weren't. You can see that from the statistics in UK Biobank even. And we assume that approaching death for any reason increases your likelihood of testing, because it probably increases your likelihood of going into a hospital. So we can assume that differential misclassification, that is people being coded as COVID negative when they're truly COVID positive, is less likely to be an issue, because assuming that you record all deaths, everyone could be in our denominator. That was all a really long way of saying we're looking at COVID deaths. What is the most appropriate operationalization of inequality? This is one that I have spent a while banging my head against a wall in an epidemiology department for, because epidemiologists, I think, broadly don't think about inequality the same way that spatial analysts would. So as far as I can tell, inequality to most epidemiologists, or a lot of epidemiologists here, is just an outcome that isn't the same for everyone. It doesn't matter whether that outcome is, it doesn't matter whether that not sameness is structured with respect to anything. It just matters that it's different. And for me as a geographer, that inequality, sorry, that difference has to have a structure for it to become inequality. So this is a little bit of a self-reflection on thinking about inequalities as functions of scale. So I think, I think spatial analysts are broadly pretty good at thinking about this kind of stuff. You can think about between area relationships and within area relationships. But I think that is something that is not very familiar to most epidemiologists here. Certainly in this department. Hands up in this department. Not all epidemiologists. So spatial independence is rarely, if ever, scrutinized as an assumption of a model. So I have found broadly that showing them this picture, which was made by Gwilym Owen, who is in the call. Obviously, this thing where I point at where the camera is for me, that's not useful for anyone else. This saying that your model cannot distinguish between these two scenarios is quite a convincing argument for most people, because so this is South Yorkshire, and these are local authority districts, the big black areas, and the little ones inside it are MSOAs, middle layer super output areas. And so we can see in the first instance that most of the variation is truly within LAD between MSOA variation. So if we were to do a single level model of MSOA mortality, MSOA counts of deaths, in the first model, we'd probably do an all right job of finding predictors of local mortality. But in the second one, if we only included our individual level, our MSOA level, we would miss the fact that most of the difference is due to between LAD differences, and that actually within LAD between MSOA differences don't matter that much. And I think multi-level models dealing with these within and between area inequalities simultaneously is something that is not really thought of that much in epidemiology here. And if it is, it tends to be done in a longitudinal space. So I think that's more or less what I say here. I think placer differences, so within area clustering, is more easy to intuit to people who are familiar with longitudinal clustering than spatial differences are. But I think that you can intuit with some classic examples that I'm sure you're all aware of. You can kind of get at stuff like this with people who aren't familiar thinking about it. So like higher individual income predicts you being more likely to vote Republican in the US, I think. Levi will know more about this than I do. But being in a richer state predicts you being more likely to vote Democrat. And similarly, if they are used to longitudinal studies, you could say between individuals being faster at typing means that you're probably more accurate at typing, but within an individual, typing faster doesn't make you more accurate, that kind of thing. We'll come back to this because it does become super important for COVID-19 studies, because I think there's something, and there's something I'll come back to at the end, because it's something I don't think I've fully wrapped my head around yet. The over-dispersed outcomes in Poisson models, perhaps you can't ever get a good predictor of them at a local level because of the inherent because of the inherent stochasticity in the measure. And so you may need to abstract up levels until you see structured inequalities at a higher spatial scale. But yeah, as I say, I'll come back to this. Final point for a causal inference flowchart: can we rule out alternative causal explanations? So we're going to adjust for confounders in our model. We're going to adjust for age structure, the number of care homes, and then we're going to see if adjusting for local deprivation does anything. And also to sort of foster confidence in the fact that any spatial inequalities we see in COVID mortality might be specific to COVID and not to do with non-COVID processes that are ongoing. We're going to run the same models again for all non-COVID deaths over the same period. And we'll compare them next to each other to see if the spatial inequalities we see in COVID are not there for non-COVID. If they are the same, then we might just be picking up something which is due to the sort of more general inequality in the UK. It's worth stressing this isn't a true negative control outcome, because dying from one means you don't die from the other, right? So they're not independent of one another. But so as this is an update, I thought I'd just quickly go over what we discussed in the previous work. So the initial paper in JCH looked at a period from March until July 2020 and found broadly that spatial inequalities in COVID-19 mortality totally dwarf those from non-COVID mortality. In non-COVID mortality, there is almost no spatial structure to your local neighborhood mortality, right? If you know your local MSOA, you know your mortality. Whereas for COVID, if you know your local MSOA, you need to know what travel to work area you're in, and you need to know what region you're in order to have a good guess at what your local mortality is likely to be. We also found that this spatial inequality varied temporally, so I'm kind of giving the game away here. I don't know why I put the slide in. But we found that inequality peaked in June, and that broadly periods of lower aggregate mortality associated with higher inequality. So that, stress that a second. So in periods where nationwide there are lower death rates, there is lower mortality, spatial inequalities get much larger, because in the periods where mortality is very high, people are dying kind of everywhere. But in the periods where there is much lower mortality, it sort of seems to proliferate in these areas which are perhaps more vulnerable by whatever metric. And as it says here, we thought that this vulnerability might be to do with deprivation, but it seems that it actually accounted to little to nothing of the unexplained variation that we had in our model. So having looked at what we previously answered, what are we going to answer this time? So this update considers data from March 2020 to April 2021. So it's about 3 times as long. And we wanted to know, spatial inequalities in COVID-19 mortality dwarfed those from non-COVID mortality. Is this still the case? Has this been the case over a whole year? Is it still the case that increased aggregate mortality is associated with lower inequalities? I think that's something we were especially interested in this time, because over the period that we're now looking at, there were different restrictions in place. So this last point, did the introduction of tiered restrictions explicitly? So Guillaume had done some work on the tiered restrictions and found basically that it looked as though tiered restrictions were effective at reducing local infections. And so did the introduction of tiered restrictions alter the relationship between local deprivation and local mortality? Because implicitly, and I'll just summarize this a bit here. So at the time of tiered restrictions, you're kind of implicitly including deprivation in your intervention, because areas with high, or pretty much throughout the whole pandemic, areas with higher deprivation have had higher mortality from COVID. And so during this period, do we see anything happen to the relationship between deprivation as parameterized by IMD and COVID mortality? So these are broadly the 4 periods I will talk about, but the one that we care about is this tiered lockdown bit. So there's pre-mass testing, which ends in like June. There's mass testing becomes available, and this is the period where, if you look in data which has, or if you look in studies which are looking at testing and testing positive, I would broadly consider this period here as not that informative for your genuine risk of testing positive. Some other work on that. But here is the period that we're interested in. So the data we use is COVID-19 mortality data for England and Wales from March 2020 through till April 2021, taken from ONS dashboards, so publicly available. And we derive non-COVID mortality from the same data set. So they give you total mortality, you just subtract one from the other. The covariates are age structures from ONS population estimates and the number of care homes from an Esri Geolytics data set, which was made available at the start of 2020 or mid-2020. And we also take the UK IMD, and we've actually, so since the first paper a new version of this equivalized IMD. So for those who aren't familiar with deprivation measures, IMD is constructed at the nation level in the UK, which means helpfully that the Scottish IMD is not comparable with the English IMD. And so this represents an empirical attempt at trying to equivalize those so that you can compare across nations. And we've decomposed that IMD into within and between scale components. And the three spatial scales we look at are governmental office regions. So across England and Wales, to give you an idea of scale, Wales is 1. So across England and Wales, there are 10 of them. We also use travel to work areas because we think these parameterize people's local commuting. They're supposed to be designed so that, I think it's 50%, somebody can correct me if I'm wrong, 50% of people who live in them work in them, and 50% of people who work in them live in them. Is that right? But they're supposed to capture functional areas of commuting and travel. And so we thought that that would be an appropriate area for COVID spread, because we know that COVID is likely to, well, we anticipate that COVID is likely to be more spatial than other reasons for dying, because you have to come into contact with someone who has COVID to get COVID. And finally, our bottom layer is the middle layer super output area. I'm going to take a drink of water really quick because I've been talking a lot. One second, sorry. So the methods, I'm going to skim slightly because I realized that I'm going to talk about quite a lot of stuff and I want to get onto some pretty pictures. It's a Poisson model, and we specify in that Poisson model a spatially invariant monthly mortality. So we calculate for each month the total mortality across England and Wales, and we divide it by the population of the area as a fraction of the total population of England and Wales. So we're saying, were mortality spatially uniform, what would we expect deaths to be in this area? And then anything which is over dispersion from over and above that, we then infer clustering or inequality from that. As I said, it's those 3 levels before, so it's technically 4 level because MSOA is duplicated to get at the Poisson variation. I'm going to say something quickly about median rate ratios because I think they're a slightly unorthodox variance transformation. But the way they're interpreted is a median relative change in the mortality rate between randomly sampled pairs of lower level units within a higher level unit. What does that mean? So it means that if I am in a given TTWA, and I find, so if I have an MSOA MRR of 2, it means that within the same travel to work area, if I take every pairwise comparison of MSOAs, the median comparison will give me a rate ratio of 2. So that the median comparison would imply a doubling of mortality. Similarly, if there's an MRR of 1, it implies there's no median difference, so there would be no inequality. If you want to see the derivation of this and some really pretty maths, I recommend this paper. George Lecky's also done another paper developing this in 2020, I think. But onto pretty results. So these are the structural MRRs for England and Wales. So this is a log scale, just to specify. So this is, you can see along the top, COVID-19 mortality. My mouse goes off the screen. And along the bottom, non-COVID-19 mortality. And broadly, as mentioned with MRRs, higher means more unequal, right? So you can see that at the MSOA level, inequality peaked around October. And similarly for region, that actually peaked in September. In region, which is this huge spike, in October, you see this huge spike in regional inequality where the average comparison, the median comparison between regions gives you a 6-fold higher mortality. Again, up to like 17, but this is log linear. So we see the main thing here, or the main thing for me here was this, that this is basically 0. If you want to know your local mortality for non-COVID death, you basically only need to know your MSOA. Knowing these other things on top of it tells you almost nothing. Whereas knowing your TTWA or your region tells you a lot about your risk of dying from COVID, about your local mortality from COVID. I made a note to myself to talk about stochasticity here, but I'll do it later. So the picture that we were asked to produce, or that I was asked to produce for someone, is this. So this is region level residual mortality. So this is not adjusting for IMD. This is just adjusting for local age structure and number of care homes. And you can see, so these are ordered by their order at the end, which isn't necessarily the order that I would have done it in. Now I'm looking at it on a live presentation. But you can see initially that London has very high rates And the Southwest does extremely well throughout this period, throughout this year. I suspect, I mean, this model doesn't take account of any truly spatial nature of these data. It's just spatial, so it's just clustering, right? So, for instance, the fact that the Southwest, the true spatial context of the Southwest is that it's mostly surrounded by the sea, so it's quite hard to get from one place to another in it, and therefore your transmission networks might be smaller. Is obviously not in this model, but I think the period that is most striking, I hope the period that is most striking is this highlighted period where we have the tiered restrictions. So areas going into tiered lockdowns at the top. So the northeast, the northwest, northwest, Yorkshire and the Humber, those all come down very drastically at this point. Their relative mortality risk comes right down, and I think that it's also worth stressing that is probably likely to do with tiers. My guess would be that is to do with tiers, but also it is the case that these areas are like London and the southeast. Though the cases, the number of deaths, the number of deaths in those areas are increasing over that period, and so it's this that makes this real shrink in variation. It's not just the reduction in the high areas; it's the increase in the low areas, and that's consistent with the introduction of the Kent variant, which we know appears around here. The question is really, can we do anything to explain this region level mortality, these region level residuals? What can we do? What can we do to explain the differences between those areas? And the thing that we can do is look at IMD, right? We can look at deprivation. Now, this is a slightly odd decomposition of these things, but so the purple line is the regional IMD, the orange line is the travel to work area average IMD, and the green line is the average MSOA IMD. So we see that it looks like, so here, at the start of October, midway through October, it looks like deprivation matters hugely. Well, deprivation does matter hugely, but it matters in a way that is broadly consistent with the rest of the pandemic. That increased deprivation gives you a higher, also increases your mortality, right? And more strongly so over this period post-summer. But during this period of tiered restrictions, and then possibly again with this emergence of the Kent variant, it actually flips. And then so by mid-January, February time, we see that higher deprivation is protective against COVID-19 mortality. And this is something which is very, very bizarre, but hasn't been seen in other papers because this would alarm me otherwise. But the reduction of the important, I think the thing that is interesting to me is that it appears that the level of the deprivation that is important for you is not your local deprivation. It's the broader regional deprivation. And as I said, I think I'll come back to this at the end, but I suspect that is to do with the over-dispersed nature of COVID cases. So if we look at what others have found, this is a brilliant paper by Morrissey et al. Called Area Level Deprivation and Monthly COVID-19 Cases. And they find, so that line is added by me, but this is, if you look at cases, you see that the most deprived have by far the highest cases until this weird thing that goes on in November, December, which I would suspect is the emergence of the Kent variant, which starts killing people people start dying in more affluent areas. Just to show where that's consistent with this period. So, having adjusted for IMD in our models, what do we see? Do we explain any of this relationship here in this window, right? It appears that region matters a huge deal. And we certainly found in our previous iteration of this paper, we found that deprivation basically explained nothing. It explained your local, it explained your fixed effect. So it explained your risk of higher mortality, but it didn't explain any inequalities in those risks of higher mortality. And actually what we find here is that this spike here is almost entirely attenuated by including IMD in our model. So this huge difference here that we see in region is actually entirely in line with the deprivation of those regions. And again, just to make the case more explicit, almost nothing along the bottom. Non-COVID inequalities are almost all sub-MSO or MSOA or sub-MSOA. And just to make the same thing more explicit, we can look at variance partitioning coefficients. So these are interpreted as the proportion of, so super individual, these are not individual measures of COVID. This is super individual, so MSOA and above, the proportion of variation in MSOA and above rates of COVID that is to do with each given level. So about 50, so a VPC of 0.5 tells you 50% of the variation can be attributed to that level, right? And so we see that for non-COVID, pretty much all of the variation is explained by your MSOA. The importance of these other levels is negligible. But we can see that for COVID-19 deaths, again, spiking in this period where we see these tiered restrictions, we see that actually region becomes much, much more important. And having adjusted for region, we see that that almost entirely goes away. And actually in this period, it looks remarkably similar to non-COVID-19 mortality in that it's almost all MSOA level. I think I'm going to slow down here and then invite questions, because that's a lot of maths and a lot of numbers pretty quickly. But I'll just whiz over some quick broad conclusions from this. We still see that geographical health inequalities are even greater for COVID-19 mortality than normal health outcomes. Sorry, normal health, other health outcomes. And that deprivation-related health inequalities are also greater for COVID-19. So we see here. They're also greater for they're greater for COVID than they are for non-COVID. And we see that the geography of COVID-19 has changed over time. So the greater regional inequality that we broadly saw before when we had lower absolute COVID mortality, I don't know if that is as strong this time. In the second wave, I don't know if that relationship is as strong as it was, because although post-Christmas we do see a reduction, post-Christmas we do see this reduction, I don't think we can still make the case that it goes completely equal, but that is totally up for debate. This is work in progress. So I'd be interested to hear what people have to say on it. And the importance of regional deprivation. So again, this is something I said I would come back to. The importance of deprivation seemed to be at the region level, which is something I've been trying to get my head around for a little while. So the idea of over-dispersion in an outcome is that, or for COVID-19, I guess specifically, is that you functionally have many, many cases where there are transmission events, right? There are loads of transmission events, and the outcome of almost all of them is that nothing happens. But in some of the cases, you get a local outbreak, and if that local outbreak happens, it very quickly spreads. And I think that one of the things that's interesting is that seems to mean that the very local deprivation isn't actually very predictive of your COVID mortality. It seems only to really be expressed because it's got such a strong stochastic component. You probably have a very slight, obviously, people who are living in more deprived areas presumably have a higher risk of transmission events. But because the vast majority of those transmission events don't do much, and it's just these super spreader events that have huge impacts, you actually don't really see that impact of that deprivation until you zoom out quite a lot, because we know COVID persists for a little while, and you sort of can imagine it as you zoom out, you start to see these ripples bouncing off each other, these tiny little ripples in a pond of extremely rare events. Well, not extremely rare, but relative to the number of transmissions, rare events becoming these super spreader events, and then those levels persisting. I'm sure Gwilym is in this chat, and I'm sure we'll do a better job of explaining this than I will. But just a couple of musings, because Levi and I have spoken about it recently. What could folks interested in spatially informed phenomena do to integrate causal methods into their work? Well, causal inference fundamentally requires random variation, and we can get at random variation in three ways. We can create it via an RCT. That's the kind of stuff that people tend to do in epidemiology, or tend to think about in epidemiology. We can assume random variation, where we adjust for things and assume that we posit that then our treatment group and our exposed and unexposed groups are exchangeable. Or we can discover random variation, where we can find natural experimental designs. And I think of these, the first broadly for geographers, perhaps unethical, perhaps unfeasible, with the exception of moving to opportunity in the US. I don't know of many instances where people have randomized their geographical context. We can assume random variation, which we do a lot. We do a lot of adjusting for stuff and hoping that we get at a causal model underneath it. But do we believe entry into our data sets is random is something that I'm not totally convinced by. If you think of an example that I often come across in reviews or in health studies. So my background is in mental health research. One of the big findings of the last 10 years, or the big areas of research, is the impact of green space on mental health, right? Loads of stuff on green space and mental health, with a positive impact being that you being around green space makes you mentally healthier. it is extremely plausible to me that the more mentally healthy you are, the more likely you are to turn up to a study. And also, the more green spaces around you, probably the more affluent you are and the more likely you are to turn up to a study. So I feel like there are these plausible reasons why these things might not be discovering true causal effects. Or we can discover random variation. And this is one I think that we should do more. Gwilym and I, again, who's in this call, and Levi are working on a book chapter about this, looking at natural experimental designs, because I think that spatial analysts and geographers, I guess, explicitly, have a great deal to offer in this domain. There's a huge amount of deep knowledge around a topic that geographers often have, spatial analysts often have, that perhaps a person designing an epidemiological study wouldn't. And so there's this broader context that often informs how you design these things. But I mean, I'm gonna shut up. So I've been talking forever. Are there any questions in that? I don't have a slide saying any questions because I'm an amateur.
Thanks, Gaz. If you want to stop screen sharing, then I'm sure that would be fine. Sure. So yes, if you're in the audience, please feel free to pop questions into the chat. Anything about sort of the three topics that he talked about today. I did have a question about the kind of assumptions of exchangeability that are made in these kinds of models. Regions aren't made equally, especially when it comes to how COVID-19 operates within them. Quite a bit of alternative work on COVID-19 focused on the concept of density, right? And your probability of interacting with other people. And I would posit that, you know, the really densely populated parts of the UK are southern regions. And those regions are not necessarily, you know, they're not all made equal, right? There are sparsely populated and there are densely populated regions, and then sub-regions within those. To what extent do you think that the kind of level comparisons that you're talking about can be understood through a lens of kind of interaction and density rather than, you know, through the region as exchangeable blocks?
I think that's a really good question. So functionally, I don't think that regions are exchangeable. I think that is often an imposition of data availability and that kind of stuff. In terms of the degree to which I think regional differences are driven by population density, is that the question?
Well, it's the interaction of, right? It's that some regions are also quite a bit less dense.
Sure. I think so. Actually, yeah. We talked for a little while about something to do with like density and deprivation, and then adjacency of those areas, right? Because of the way that we know COVID works, or the way that we imagine COVID works, and we suspect it works given evidence. Transmission events are more likely to happen in densely populated areas, and they're more likely to happen in deprived areas because of people. So there's a lot of work on. I mean, there's an amazing paper on. It's called Zoom Shock, the paper or something, but it's basically the ability of people to work from home and their IMD quintile is almost perfectly correlated. Right? So people who are in more deprived regions are less able to self-isolate. And I think that will be picking up. I think that one of the things that I don't like about this project is basically that IMD is a rubbish measure of anything, but it's quite a good measure of loads of things. So I think if we were to pick it up, we'd pick it up somewhere between travel to work areas, because I think are functionally supposed to capture some of, they are more, it's my understanding that they're more spatially heterogeneous in size than regions are. I think we'd basically explain away a useless amount of it in including IMD, and we wouldn't be able to pull back out the effect of population density other than knowing that density is in the IMD somewhere. But I think that it's a great point, because yeah, one of Gwilym's pet theories for a while was that part of the reason that things perpetuate in certain areas of the country is that you might have, he at the time framed it in terms of like deprivation adjacency, but it could very easily just be population density adjacency, right? If there's an outbreak in an area which has high population density or high deprivation, it's spatially buffered by the areas around it, and the areas in the south which are more deprived tend to be coastal. Yeah. And coastal areas which are surrounded by sort of affluent bits, whereas in the north that seems to be less the case. But yeah, I think it's a great idea. I'm now going to think about that for a while.
Well, the density, I only ask because there was quite a bit of work on this concept of lived density, as you're talking about, like your probability of interaction or these kinds of things. And at the regional level, that density gets very heterogeneous very quickly. So I was just curious about that.
No, that's a great point. Thanks, Stephen.
There's one question in the Q&A, which is, could you talk about the policy implications of COVID impact measures?
COVID impact measurements, as in the selection of COVID. Sorry, I don't know who that is.
I suppose it's more about the kind of implications of what your findings about the impact of COVID have for banking policy. Like you mentioned earlier, that these tiered systems work, or in a sense, something like that.
Yeah. So I think the first half of that is in terms of if you're going to try and make a robust policy, you should get a robust outcome. I think that there was a lot of stuff done, possibly by necessity, but early on there was a lot of stuff done on basically COVID self-report. I did bits of it in ALSPAC here, which is in Bristol, is the children of the 90s cohort, where we're looking at self-report amongst people, but it's extremely non-random. Participation in those data sets is extremely non-random, and I think that basically means that for useful public policy, it's quite often of limited use. I absolutely think it has value, and I think it offers something, but I don't think that it is. I don't think it's as robust as all that people kind of make out. I think in terms of the policy implications of the tiered restriction-y bit, I think it's just an association, right? It's my positing of the fact that it's to do with tiered restrictions. It looks as though tiered restrictions do something, but the inverting of the IMD relationship is almost certainly to do, well, almost certainly is probably very strong, but I think it's going to be a lot to do with the fact that the Kent variant emerges in Kent, and that is by I was going to say by design, that's not really by nomenclature, it comes about in Kent, and I think that then flips the relationship, and things like that are basically stochastic. You could sort of make the case that because case rates were high in Kent, because it wasn't in a tiered restriction, it is more likely that a variant emerges. But I think just fundamentally, this stuff is all completely new territory to me, because I'm not used to modeling things that are genuinely stochastic. There's some amazing work there's a Volz et al. Paper in one of the, I think it's in Cell, from like midway through last year, which looked at they genuinely did the genomic lineage of like 20,000 tests in the UK, and they basically show that like evolution is genuinely stochastic. Like the number of singletons is like hugely higher than the number of like consistent lineages that ever emerge, because most of the lineages that emerge just die out immediately. And I think the idea that this viral evolution or this over-dispersion thing can be meaningfully patterned by space. I think there's an interesting question in there about whether you can make meaningful social policy around things that are genuinely stochastic, beyond just providing universal and buffering universal support for people. Sure. Perhaps some of the stuff that we were initially thinking with this, that you might be able to come up with targeted local things. The local in that targeting is going to be quite a lot broader than we initially thought it would be. Sure.
That makes sense. And then I guess one last question from me would be, would you think of the imposition of tiered restrictions as a natural experiment? Is that the frame in which you want to understand that study?
That is a really good question. I don't think it's a good natural experiment. Mm-hmm. Just because there's so much other stuff that is changing at the time. I think there was a case made. So if Gwil's there, Gwil, can you unmute yourself? Is that a thing that you can do? Okay, never mind.
It's a thing I can, or
if you find Gwilym and just forcibly unmute him and bully him into speaking.
I'm allowing him to talk.
He better be there. If he isn't there, I'm going to message him immediately after this and call him. But he did a paper which was looking at, basically it was a really nice spatial design, because tiers were prescribed at local authority level, right? And they were prescribed based on local case rates, and case rates are available at MSOA level. And so functionally, you could do this matching where there were MSOAs with identical case rates in different LADs, tiered LADs. And so they were looking at the difference between tier 2 and tier 3, which I think was the difference between going to pubs and not. And based on this matching, this covariate matching, Will, are you there?
Yeah, I'm here.
I would apologize,
quite
but I'm not at all
expecting it.
sorry.
But yeah, I mean, I think you pretty much explained it. We kind of did a synthetic control analysis, looking at because the restrictions that were implemented at the local authority level. You can find areas within each local authority that have similar trajectories of cases and similar characteristics, which you can kind of match on, that kind of thing.
Do you think it's equivalent to a natural experiment?
Yeah, I guess it's kind of a natural experiment.
It's close, yeah. Right? I think you can kind of make the case. I think that there's a case for locally targeted policy. Also, I think we should. I mean, I don't know. Me and Gwen were talking about this the other day. We should just experiment more. It's weird that all of our social policy experiments are exclusively costed to be done in sub-Saharan Africa. I don't know what that says about our moral scientific apparatus, that we are only willing to do experiments with social policy in brown people because they're closer to lab rats or whatever that means. It's not a thing that makes me hugely comfortable. But given that we're rolling out social policies in the UK anyway, you may as well make them spatially random. And so stuff like, we were talking to some people here about rolling out parks in Bristol. Green space is one of the things, because of all the green space mental health literature, right? The parks are something that they're investing in, and we were like, hey, you may as well randomize this. Like, there's not, there are reasons that people might not want more parks in Clifton. I can totally understand that. But if you do randomize it, or if you do try and break some of the chains of selection, then you can. These policies are being implemented anyway. You may as well try and introduce some exogeneity into them.
I think I'll pass over to Rachel to ask a question.
Sure.
Well, I always like to say something. It's maybe more of a reflection, and maybe you just want to comment or not in the last few minutes, but it's not the first time that we've had these conversations where we realize that maybe the challenges that we face don't lie in the methods, but in the data, right? And in particular, I think in your case, sort of study design. I mean, it's experimentation, but it's also sort of understanding where your data come from, right? And a lot of times we're dealing with data that weren't collected for the purpose that we're using them for, or there are other challenges. And then we do all these acrobatics with our methods to somehow try and like get around the problems that we're pretty sure might exist. And so, yeah, I mean, I don't know. It's just interesting to me that I think we call this spatial analytics and data, this seminar series, but we tend to lean on the analytics, maybe because that's the piece we control.
Absolutely.
But really, I think there's an argument to be made for taking a long, hard look at our data.
I think that I think basically I would be putting myself out of a job at some point if I were totally honest about at what stage in the does my data genuinely let me answer this question you walk away. The stage at which I think that it probably is worthless is not a stage at which I would be particularly employable. In terms of me going forward as a spatial analyst, I think again, especially in the sense that so many of these policies are being deployed anyway, it makes sense to have analysts, spatial analysts of any kind involved in the policy framework that is doing them. So.
Yeah, I mean, that's another point, right?
I think that it's like a I think that basically as it stands, we sort of, if you want to get close to causal inference, we're writing a book chapter with Levi on this kind of stuff. And we're saying if you want to get close to causal inference, you have to try and find these natural experiments, which basically currently involves you having like some knowledge of some arcane policy experiment somewhere where someone, like some bureaucrat, randomized something and then immediately.
Right. Although, and I realize now we're running out of time, and this is probably a much longer conversation. So this might be a pub conversation in the after times. But I mean, it seems to me this is where a page from economics could be taken, because it's not only this sort of strategic and, in development economics, I would be absolutely completely with you on where the sort of designed experiments take place. On the other hand, the sort of creative search for accidental or almost experiments that is sort of built into the way a lot of economists are trained, I think is something that I don't fully understand why geographers haven't picked up on, because when I've taught economists, that's exactly what they want help with. They've found a spatial accident and they need help operationalizing it. And so I think it says something about training and sort of the way geographers approach the world, because economists are very comfortable looking around and probing to see whether it holds that these spatial accidents or experiments have actually occurred.
I think the point on that really, I totally agree. The point on that really is that because those instances of natural experimentation are so, like, they're very hard to find, and they're basically so Byzantine in their design, and in that you have to have someone whose job it is to look for natural experiments and then retrofit a theory behind them to be like, that's the experiment we always wanted to ask. And I think that actually, if you involve analysts in the design of policy from the outset, then you don't need that level of arcane knowledge, because you can be like, hey, let's just design the experiment from the outset, and you remove that barrier to those things. And if you integrate more closely with the policy folks at that point,
yeah, no,
you don't need this huge layer of added labor of people just being like huge policy wonks. Like,
Levi has heard me complain about this where sensor placement is concerned. Yes. I mean, we just don't think about it ex post facto, and then afterwards we want these data to be usable from a policy perspective, and they aren't really not fit for purpose, as they say in this country.
Or you need a massive amount of statistical machinery to try and make anything concludable.
Oh, I see Emmanuel is saying we're not geared towards designing policies. A good economics paper needs to have policy implications. A good geography paper, not always. Yeah.
I think that's true. It depends what your aim for geography is. There are lots of questions which aren't causal, or there are lots of things where describing them is useful.
Yeah, I would say, Emmanuel, you should join us in the pub, because I would say that geography should be thinking about policy implications. Anyway, I'll be quiet now.
I would just because I'm conscious that it's late for some attendees as well, and we appreciate you coming along. Join us next week, same time, same ethereal place, for our conversation with Sarah Fabricant, professor at the University of Zurich. Rachel, Daniel Erbespel, and I will be interviewing her about her life, her work, and who she would bring to a dinner party. So thank you very much for coming, everyone. And appreciate everybody taking the time today. This will go up on our YouTube channel, like all of our events, and you can find more about us on Twitter as well. Thanks a lot, and we'll talk to you later.
Thanks so much, guys.
Hi, thank you, Gareth.